Thank you, Alberto. And now the next speaker is Frank Cobelens from KNCV and AIGHD. And the talk is the evolving concept of latent TBI diagnosis, test for incipient tuberculosis and test for persistent infection. Frank?
Thank you, Daniela. Good morning, everyone. So already last year during this same meeting, we introduced this concept, and so the presentation I'm going to give has a number of similarities with what you've seen last year, but we have hopefully managed to think through this concept a little bit more in terms of what it means for test performance and test utilization. So this is my conflict of interest disclosure. And so there have been an awful lot of studies looking at tuberculin skin testing and IGRA for all sorts of outcomes. But what we are really interested in as an outcome is progression to TB disease, which means actually we have to look, in order to know how well these tests perform, we have to look at prospective studies that either compare those who are test negative to those who are test positive with regard to their outcomes, which gives us sensitivity and specificity for these tests for progression to disease, or we can look in those who are test positive only, and it gives us the positive predictive value, which, just to remind you, is the proportion that really has, in the end, progresses to disease out of those who test positive. And there are examples of results from those studies. This is from a systematic review done by Ronald Deal a couple of years ago, but I think that what is here is still valid, even though other studies have come out in the meantime, that looked at IGRA as a predictor of TB disease. And this particular forest plot is only looking at high-risk groups, and there you see that the pooled positive predictive value for progression is less than 7%, which is very, very low. And interestingly, if you look at all these studies, then you can see that those that were done in low incidence populations, mainly in Europe and Asia, you can see that there is still a relatively high positive predictive value. It's not great, but it's about on the order of 15%, whereas those studies that have been done in immigrants, which can be considered high incidence populations, show an appallingly low positive predictive value. We'll get into that later on. And there is a different way of looking at it. This is from Sandra Kick, who was one of the authors on this study. It isn't out yet, but this is a systematic review of all sorts of studies that looked at the predictive value of IGRA for subsequent disease, and actually calculated pooled sensitivity and specificity. Those are the numbers up there. And what the graph actually shows you is the association between here on the x-axis, basically the probability in that study population that persons at the end will have tuberculosis disease, and here it's the number needed to test. So that's the inverse of the positive predictive value, which means that it's the number of persons, number needed to treat, number of persons that you need to treat with preventive therapy in order to prevent one case of tuberculosis. And then you see that these numbers needed to treat go up immensely when you go down in the lower areas of cumulative incidence. And just to give you a flavor, this is what we usually will see among HIV-positive contacts, a progression rate of about 5%. So you see that you're already up to almost 100 needed to treat. Whereas if you go to where we would actually want to use the test in HIV-negative contacts, prisoners, let alone those who have even lower risk, then the number needed to treat becomes enormous. So that basically means that we need a test that has better positive, also better negative, but we are concentrating on the positive predictive value for TB disease occurring in the future. And then a couple of sort of terms for this kind of test. I think we should do away with an LTBI test. First of all, we basically don't know what LTBI means, and we also don't know what then the particular utilization of that test would be. Others have proposed risk stratification tests, but I'm not at all sure that this kind of testing is about risk stratification. So I thought, let's keep it simple and call it a TB prediction test. But we're going to make it a little bit more complex, because the question is, can high positive predictive values be attained? And then we have to take you to the changing paradigm of what latent tuberculosis infection is. And this is from a now famous paper by Cliff Berry, and it shows you that so this is the sort of current thinking now, that instead of just having the classical dichotomy of latent infection versus clinical disease, there is actually this whole continuum, this whole spectrum, where in the sort of early stages you can have elimination of the infection through the innate immune response. Later on, there can elimination of infection be by the acquired immune response or by T cells. But then there is, before you get into clinical disease, there is the sort of classical notion of latent tuberculosis infection, so infection controlled with some bacteria that persist in non-replicating form. But then there is also this active phase here, or active subclinical phase here, where you would have bacterial replication at a subclinical level, sort of controlled by the immune system, but which can in the end lead to some sort of disbalance leading to clinical disease. And there was also more thinking gone into what that kind of disbalance could be, and I very much like this particular hypothesis or model which had been put forward by Hanif Ismail in this review here of last year. And he actually proposes that what we actually have is infection, and then particular predisposing factors can sort of determine whether the infection leads to stable infection, controlled, perhaps even completely eliminated, or unstable infection. And in case of unstable infection, what you would actually need is some sort of precipitating factor that, so in the unstable infection, you would have sort of on and off bacterial replication at very low levels, and all of a sudden something happens by which it takes off. And then you get into disease, and then there may still be somewhere here the possibility that this progression to disease is actually halted. And I think it makes sense to think about latent infection in this way, because it explains to some extent why these progression rates are so low, because we probably need something like this, like a precipitating factor. Of course, there's been very little work into this. We don't know what those would be. There are a couple of possible candidates have been proposed. So, and if this is indeed a model, then we would have, so it would look like this. So you have this situation of unstable latent tuberculosis infection, in which you would not be able to see anything by imaging or by bacteriological diagnostics. But at some point in time, after this precipitating event has taken place, there is a prolonged period during which there is subclinical active, or as I like to call it, incipient tuberculosis, which can still revert back to this stage, but can also continue. And before, only here we will have, a patient will have symptoms, so there will be sort of clearly identifiable symptoms of tuberculosis, but long before that, there will, at least with some techniques already, imaging will already be positive, and at some point in time, culture will be positive before there is actually clinical disease. And we are increasingly recognizing that this is indeed what is happening. This is a review of the tuberculosis prevalence surveys that have been done over a period of 20 years in Asia. And it shows you the proportion of all detected prevalent TB cases that did not report cough. So these people had no cough. And especially if you look at the right-hand panel, the bacteriologically positive, you see that more than 50% of those cases, prevalent cases identified, and that had a positive culture and had abnormalities on the chest X-ray, because that's how they were identified, had no cough, no sort of classical tuberculosis symptoms. And there is very recent evidence, this came out only this month in Nature Medicine, also by Hanif Ismail's group, that used PET-CT scans and a PET-CT scan actually gives you information about whether there is inflammation ongoing. And this was a study of 35 patients with latent infection, HIV infected, not on ART, in whom these PET scans were done, and they showed that there were 10 out of those 35 that had activity, so that had inflammatory activity in the lungs. And out of those 10, the majority, as you will see here, progressed to TB disease over a follow-up period of 6 months, whereas none of those who didn't have any of those abnormalities progressed. So I think this is also a strong indication that this might actually happen, and that this is actually quite a prolonged period of time. So if we take indeed this paradigm, then we can sort of distinguishing these two phases. We can say that if we test in this phase, in this stage, then we cannot predict if and when a precipitating event will occur. So we cannot predict that this will actually happen. So that means we cannot predict who will become diseased. So the positive predictive value will be inherently low. Whereas if we test in this phase, then there is active bacterial multiplication with actually high probability of leading to tuberculosis disease. So here in this testing, here in this stage, can give us a high positive predictive value. So then that means that we can sort of conceptualize two types of tests. So one type of test will be what I call a persistent infection test, and that's a test that would basically predict that disease cannot happen if it's negative. Disease cannot happen because there is no persistent infection. The alternative is here a test that is what I would call an incipient TB test that will predict that disease will occur because it has already started. So it's not really a prediction, it just tells us that it is already happening, it's just that we're not observing it clinically yet. So what? So what does this matter, this dichotomy? I think it does, and I think it matters for 4 areas: for development, performance, utilization, and design of tests. So very briefly about development, this is basically the question, what kind of test would this be? So a persistent infection test would probably be a test that gives us some information on the CD4 response, but like we already have with the IGRA, for example. But potentially also messenger RNA tests, and there are especially for specific some of the genes. Whereas an incipient TB test would probably be a test of bacterial multiplication, perhaps also messenger RNA for different gene expression, inflammatory response, perhaps CD8 response. If we look at performance, now things become a bit complex, and I'll take you through this first by showing you, because you are going to see a couple of slides with this graph, and I'll take you through this first, so that you understand what we're looking at. So this is actually what can happen to someone who gets infected here, or who actually may have been infected already and then gets reinfected here. So there's a probability here, D, that the person has already has some sort of a persistent infection. And then, so the infection can be cleared, spontaneously cleared, governed by this probability. A persistent infection can sort of be maintained with no tuberculosis in the end. Persistent infection after some precipitating event can lead to incipient TB, but it can also still be halted and revert back to the state of persistent infection, which means that also here there would be no TB. So only in this case we would end up with tuberculosis, and these are the probabilities that govern this. And the PPV, the positive predictive value, is then the true positives out of all the positives, and you will see them in the next slide. So if we think about a test of what I think is a test of basically anamnestic response, like the tuberculin skin test, that test is actually expected to be positive in all these arms. So that means that the positive predictive value is these true positives out of all those. So the PPV for predicting TB disease will be very low, which is true for TST. Now, if we would look at a true test for persistent infection, meaning that it doesn't pick up those infections that have been cleared in the meantime, so it reverts to negative if an infection is cleared. Now, these will be true negative, but these will be true positive, so the positive predictive value will still be relatively low. Now, it's important to understand that this positive predictive value here is governed by these probabilities, by B, by C, and by D, which means that it is dependent on the risk of disease progression, and it's also dependent on previous exposure, which means that the PPV is population dependent and will be lower in high transmission settings, because then D is very high. This is exactly what we see with IGRA. So probably IGRA is some sort of persistent infection test, although we don't know whether it really becomes negative, and I think there's quite a bit of controversy about it, from the studies that have been done, whether it really becomes negative if an infection is cleared. If you would have a test for incipient TB, it would only be positive in these two cases. So either leading to tuberculosis or halted progression. So here the positive predictive value can be much higher. It will be largely population independent, because it's not anymore governed by these factors, and especially not by this one. The problem, however, is that the test will only be positive if we test here, if we test after this event. If we test before this event, it will be negative. So the negative predictive value will depend on when the test is done, which also will mean that the negative predictive value will be higher the closer the test is done to the moment TB disease becomes apparent. Now, this is a bit of difficult concept because we think in reverse, but this is exactly what you've probably seen this paper in the Lancet earlier this year from the South African group, a great paper that looked at these 16-gene RNA signatures and showed that it had a sort of reasonable predictive value. Now, interestingly, this is exactly what they did. So they looked at when tests were done and when TB in the end was diagnosed, and they sort of realigned this, and then they basically showed that the closer the test is done to the moment that TB was diagnosed, the higher the positive predictive value was, which is very much in line with what I just said. Okay, this also brings us to implications for test utilization, because a test for persistent infection is basically a rule-out test. As I said, if it's negative, it tells us something. If it's positive, it doesn't tell us an awful lot. Whereas this, the Incipient TB test, is a rule-in test. It doesn't tell us an awful lot when it's negative, because it depends on when we test. But if it's positive, we will probably have a high risk of progression to the TB disease. Now, what does that mean? When should we use a rule-in and when should we use a rule-out test? Now, our idea is that a rule-out test, so that's a test for persistent infection, is relevant in persons who have a very high probability of progression, especially to severe disease. For example, HIV infection prior to TNF-alpha blocking therapy, infants, and so on. And that would be irrespective of recent exposure. So it's basically the test that we are currently using in clinical practice. Whereas for a rule-in test, so the Incipient TB test, there I think the main application would be in those who have been recently exposed, which could be contacts of an infectious case. But for example, anyone in a high transmission setting, I think anyone in a township in Cape Town is recently exposed by definition with this tremendously high force of infections that they're seeing there. That would be irrespective of the probability of progression, because we're actually beyond that probability B. And that means that these tests carry potential for mass test and treat campaigns, which has implications for the test design. Because if we would do this, so again, an Incipient TB test would be a rule-in test, could be used at large scale. It will have a low number needed to treat, what we're aiming for, but we need to test an awful lot of people, probably because we have to repeat it. So this means this is only a useful test if it can be low cost and easy to use. Then it can be used for mass test and treat. And then the risk signatures, I'm coming back to that concept, for example, the messenger RNA one may in fact be combinations of both, may in fact look partly at persistent infection and partly at Incipient TB. So, conclusions. First, what we need is a TB prediction test in order to gain sufficiently high positive predictive value. They're now too low and numbers needed to treat are too high. A high positive predictive value test probably identifies Incipient TB rather than persistent infection. A test for Incipient TB will be a test for ruling in likely progression to TB disease in recently exposed individuals. And finally, an inexpensive and easy-to-use test for Incipient TB could open opportunities for mass test and treat campaigns. And these are the other people who have put their brains and other help into this concept. Thank you very much.